Welcome to our first ever Soft Bones webinar. And this is a really exciting opportunity for all of us to get together and learn more about hypophosphatasia, as well as to learn more about what's being done in the advocacy arena by soft bones. So I'm thrilled to have everybody here on the line with us today. Okay, next slide. Just a quick overview of today's agenda. I will go first quickly. We only have an hour, so I want to jump in and not waste any time. We're going to start off with soft bones, just doing a quick short 10 minutes to tell you about advocacy for hypophosphatasia and what we're currently doing. And then I'm going to turn the presentation over to our guest presenter, Dr. Cheryl Rockman-Greenberg. Many of you know Dr. Greenberg already, just from word of mouth, or some of you may actually be her patient. But she is the Director of the Metabolic Services and a clinical geneticist at the Program in Genetics and Metabolism, professor at the Department of Pediatrics and Child Health and the Department of Biochemistry and Medical Genetics at the University of Manitoba. Dr. Greenberg, she got her MD-CM from McGill in 1974, and she became a fellow of the Royal College of Physicians and Surgeons of Canada in Pediatrics in 1979, and in Medical Genetics in 1996. She's been a fellow of the Canadian College of Medical Geneticists since 1982, and she served as Medical Director of Child Health Program, WRHA, and the head of the Department of Pediatrics and Child Health at the University of Manitoba from 2004 to 2014. So, Dr. Greenberg, welcome.
Thank you.
And of course, I'd be remiss if I didn't say a special thank you to Global Genes. They're our advocacy partner, and Global Genes, they work with advocacy groups like Soft Bones, and they've become one of the world's leading rare disease patient advocacy organizations. They began as a grassroots pretty recently in 2009 with just a few rare diseases, over 500 organizations around the world. So they were the ones who allowed us to tap into this webinar technology, which in turn saves us important fundraising dollars. So I want to thank them for their support. Okay, next slide. Housekeeping item. We're going to be collecting questions throughout the course of the webinar, and you'll see in the bottom right-hand corner there's a little Q&A window. You can select an area. We'd like you to address all of your questions to the host, and we will take questions at the end of the presentation. Most likely we won't be able to get to all the questions, as again we'd like to keep this to an hour, but we will be collecting all of the questions and answering them and circulating them after the presentation. So be sure to ask any and all questions that you have. And finally, one quick note, any questions about the clinical trial just can't be addressed during today's webinar due to the regulatory consideration of aspartame alpha. So we'll have to limit the questions to clinical experience, disease questions, and other things. So just make sure that you keep your questions relevant to your clinical questions around hypophosphatasia. Okay. To Soft Bones, the U.S. Hypophosphatasia Foundation, and as we said, hypophosphatasia, the Soft Bones Hypophosphatasia Foundation, we have a presence in the U.S. clearly, but we also have a presence in the U.K. and in Canada. And in Canada, we're actually in the midst of formalizing our presence from a legal perspective, which is really exciting. We'll talk a little bit more about why that's important in my short presentation coming up. Next slide. So hypophosphatasia began actually a decade ago yesterday. My Canon turned 10 years old yesterday. I gave birth to Canon on April 26, 2005, and my story is very similar to a lot of yours. He had very typical symptoms. He missed a lot of his milestones. He wouldn't bear weight. He wouldn't sit strongly. He was diagnosed as having hypotonia or low muscle tone at a very young age, and he started physical therapy. And then he lost his first tooth that came out with the root intact at 12 months. Large skull when they would do the measurements, and just a lot of things that kind of, I would go, something doesn't seem quite right here. And we started on that journey toward trying to find out what was going on. And it took an aggressive search where his father and I were really very insisting something was wrong. It took about 18 months for him to get diagnosed. The child had formed. And that's when the questions began. You know, I kept thinking, who else can I talk to about this? And who else has been through this journey? And what can I expect? Where can I get accurate information? And what can I do to help? Next slide. And that's when Softbones started. So we are a 501c3, which is a nonprofit designation here in the United States, which basically means that we are a full-fledged charity, and we're a tax-exempt organization. And our mission is to provide valuable information, education, and support for people living with hypophosphatasia, their family and caregivers. The foundation also promotes research of this rare bone disease through awareness and fundraising efforts. Slide. So I asked a lot of times, you know, what do you really do with soft bones? What, you know, you're raising awareness, right? And I say yes, but I kind of caveat that because I've learned that the advocacy world is very complex and complicated once you really get into it, and goes into a lot of different areas. But, you know, I thought this was a good slide that kind of captures what we do. You know, we really look and work with patients and our partners to identify any problems that they have, gather information around the problem, and really understand the landscape, make a decision on what we should be doing based on the information that we gather. And from that, we formulate a plan, and we take action, and we measure and evaluate as we go along the way. And we do this on an ongoing basis in several different areas. Next slide. So you see, these are our areas of focus. And, you know, while they are all distinctly very separate initiatives, they overlap in quite a few areas. And I'll talk a little bit more about how they all fit together in just a minute. But you know, we educate, we help promote research, we do fundraising to obviously fund our activities, we provide support and caregiver support. We also help with access issues, and we do some work on the political policy front. And then we support community outreach from a very grassroots perspective. Next slide. So, I mean, what does this mean to me? So if you think about that last slide, you know, if we support each other and we start this dialogue, you know, every patient, especially when you're dealing with a group who has this rare disease, but a huge severity of a spectrum of severity, that we have important insights that we learn from each other. And from those insights, we can share those with all of our stakeholders so they have a better understanding of the disease. And from that, they are more aware of the disease, and that can lead to more patients diagnosed, which helps spur more interest in research, because the more patients who are diagnosed, the more interest there is in more about the disease and more research among the current researchers. And the more research we have, the more demand for funding we have, which hopefully leads to more support from government. So you can see where the policy piece is driven by a lot of our efforts. And then on the industry side, from a research and development perspective in R&D, you know, the more people that they have diagnosed, obviously, is more important for them to be able to develop drugs and see that there's true need. So all of these things boil down to, you know, to improve the lives of patients living with hypophosphatasia. Next. So what we do when we first started Softbones, we started out by hitting the reset button, because one of the things that was very clear to me as the mother of a patient who was newly diagnosed is that there was a lot of misinformation out there, a lot of wrong information. And I felt very determined to figure out, well, what's accurate and what is real information versus what is not real. I had lots of families giving me advice on different types of formula to feed him, different supplements, and I thought, you know, here I am, I'm basically giving my newborn child supplements in his bowl, and I thought, this is crazy. I could be doing something really awful here. So we started by creating this multidisciplinary advisory board, and we have experts from all of these different areas on our board to help us to navigate some of these questions, especially on the endocrinology side and helping to create materials to educate other doctors, create materials to educate patients and our other constituents. So this board is really at the crux of everything that we do. Next slide. There, we were able to build our kind of cadre of education materials, everything from our website and also other educational materials like our we have a genetic guide, we have a patient brochure with a general hypophosphatasia overview for physicians, to creating a Hypophosphatasia Awareness Day. This was a big initiative that happened through our global alliance. We actually have relationships with hypophosphatasia groups in Japan, Germany, and France. We get together once or twice a year and we talk about how we can all come together so that we're not reinventing the wheel. And we actually just recently decided to have an effort to have HPP Day recognized internationally. So we're working with the World Health Organization to do that. Work together to get media coverage. We have our Facebook page, and we have our Brain Pop video and things that a lot of you have seen before. On the research side, we have educational research grants that we provide to budding researchers to help stimulate new in this disease and new ideas around potential treatments and possible ways to stimulate that thinking on the academic side. And then we also support research by providing grants and supporting some additional engagements with researchers and academia. Access and policy front, we've actually worked with the Social Security Administration to make sure that hypophosphatasia is recognized as a rare disease. When we first started Soft Bones, people were complaining that they had trouble getting disability benefits because they knew what hypophosphatasia was. So we worked really hard to get it listed, and we still have some work to do on the policy front around getting people access to not only the hopefully potential treatment coming down the road, but to the benefits that they're enabled to have as somebody who qualifies as somebody living with a disability. And then we do some work with, in Canada actually, we have some very active efforts going on around the potential treatment coming and helping to educate patients who live there about and how just because a drug has regulatory approval doesn't mean that they will automatically be able to get it from their doctor, because there are all sorts of reimbursement issues that they have to face. So we're working to educate all of our constituents in Canada on that and work together to show the role that patients and advocates can play in making sure that everybody has access to this important therapy. Our lobbying day and our congressional briefings that we do. So this is just a very top-line overview. We do a lot more than this, but I just wanted to give you a flavor in all of those different buckets. And our patient meetings. Next slide. So this was our first patient meeting that we had in Chicago. We had a wonderful turnout. We've had 3 since then, and we have our 4th one scheduled on June 26th and 27th in Orlando. And for any of you who can join us, we'd love to have you. These meetings have been wildly successful, and it really helped all of our different audiences to bring together patients who've never met another patient, or moms who want to talk about caring for their children, or fathers who just want to, talk about their feelings and going through this journey together. And it's been such a huge, huge success on all fronts. So I think that every person who's ever come to one of these meetings says that they've left really having changed the way they think about hypophosphatasia, which is, again, so important when we have a disease with such a wide spectrum of severity. Next slide. For cute pictures. I just wanted to share these because we found our Awareness Day activities. Obviously, awareness goes on all year round, and you can always get a T-shirt or a bracelet to help us and to get involved. But we are, again, actively pursuing international designation of October 30th as HPP Awareness Day. So we're all working together to get that recognition from the World Health Organization. A few minutes over time, but I want to not take another moment to turn the, the phone over to Dr. Greenberg for her overview of HPP. Dr. Greenberg?
I hope everybody can hear me. You know, after hearing your overview, knowing how much Soft Bones has accomplished over the past few years, you wonder if my clinical overview is really necessary, but I'm absolutely honored and I feel privileged to be able to give, you know, my perspective of a clinical overview in hypophosphatasia. And again, I want to thank you very much for asking me. For as long as I can remember, I've always wanted to be a pediatrician and especially a doctor for rare diseases, and that's why I became a geneticist. And I'm just going to, I think I can advance my own slides. I should be able to. It's not, but he'll need you to advance them for me. I thought I could. Okay. This is my disclosures in terms of my involvement as the principal investigator for clinical trials for Alexion in Canada. And next slide. Those of you who are listening to the webinar and watching the webinar may not know exactly where I am. I always like to make sure people realize where Winnipeg is. I've only had one job since I finished all my training, my fellowship training as a metabolic geneticist, and that's in Winnipeg at the University of Manitoba. Winnipeg is in the geographic center of Canada, and we're about 1 hour north by plane from Minneapolis. And all those dots, the black dots on the map of Canada, are really all the specialized metabolic centers that are generally within academic pediatric centers in Canada. So you can see there is representation in metabolic specialists from coast to coast in Canada. And we're a very tight-knit community. And I'm the principal investigator for clinical trials all of Canada, but anyone in Canada, any of my colleagues or any healthcare professional know that they can pick up the phone and call me at any time. So though we're a very large country geographically, we're small in terms of numbers and very, very close-knit. Next slide, please. In fact, I became involved in hypophosphatasia when I first moved to Manitoba in 1979. But at that point, I learned that the first English report of hypophosphatasia actually came out of Winnipeg. And it was in 1935, and it was published in the British Journal of Surgery. And it was actually a report of sisters of English and Welsh descent. And in retrospect, of course, alkaline phosphatase wasn't measured at the time. This is really felt to be the first report in the English literature of hypophosphatasia. And it was made by Dr. Bruce Down, who was from Winnipeg. Some of you may know Dr. Bruce Down's name. He's very famous in Canada because he and his team were the ones who developed RH immunoglobulin, has prevented RH disease of the newborn. He could have continued on hypophosphatasia work, but he went into the RH field, which is just as well, because he's done such an amazing researcher in Canada. But you can fast forward several decades, and it was Dr. Fraser at Sittig Kids in Toronto who then identified and really described the clinical classification at the time of hypophosphatasia as having three main forms: the infants, children, and adult form. Next slide, please. Then the clinical classification, which is one that's still used today, then divided the infantile form into the neonatal and then to the later infantile form. And knew for many decades now there is much overlap between classes, and it's been pointed out by others. It's really on a spectrum of clinical involvement. And of course, there is a type that only involves the teeth. That's called odontohypophosphatasia, which I'll talk about later. Next slide, please. in the field of the metabolic geneticist, we call hypophosphatasia, or HPP, as I'll refer it to, as an inborn error of metabolism, IEM. Inborn errors of metabolism, these are genetic disorders, and they're single gene disorders caused by an abnormality or deficiency in one enzyme or one protein caused by an abnormality in one single gene. In our encyclopedia of genetic disorders caused by abnormalities in one single gene, there's well over 7,000 disorders caused by abnormalities in one gene, which hypophosphatasia is just one of over 7,000 disorders. And you can see there's still a lot of work to do because of the 7,000 single gene disorders, only about 3,400 do we know what the causal gene is. And of these, 550 or so are termed inborn errors of metabolism, where you know what the missing protein is or the missing enzyme. And that term was coined actually by a British researcher, Sir Archibald Garrett, and knew that an inborn error of metabolism means that there is a block in metabolic pathway. Here is a substrate that has to be converted to a product, and an inborn error, you're missing either an enzyme or a helper enzyme, and the ramifications of the missing enzyme is that you either get accumulation of a product before the enzyme block, which itself could be toxic, or you're missing the end product. In hypophosphatasia, it's obviously we're missing the end product of calcium phosphate, hydroxyapatite crystals. But it's an inborn error of metabolism, and each one of these disorders, of course, is very rare, but collectively they constitute a significant burden of disease. Next, please. Hypophosphatasia, many of you know of it as a rare, inherited, potentially life-threatening metabolic disorder. It's found worldwide. Its prevalence is overall unknown, but the estimates are about 1 in 100,000 live births, which make it a rare or ultra-rare disorder. In some populations, and I found that out as soon as I moved to Manitoba from Montreal, that there are some populations where it is overly represented. And within Canadian Mennonites, people of Mennonite descent, especially in Manitoba, we have a much higher frequency than in the general population worldwide. 1 in 2,500 babies are born with hypophosphatasia who are of Mennonite descent. There's also a high prevalence in Japan. Next, please. An example of the work that I got started in the hypophosphatasia world. This is a family tree of one of the first families I became involved with when I first moved and started to work here in 1979. Shortly thereafter, I realized that we were losing babies to this very severe bone disease called HPP, and the arrow refers to the two initial babies I saw really in 1980, 1981. They were first cousins. The circles are females, the squares are males, and this is a sixth-generation family tree, and although it may be hard to appreciate, there were a lot of babies who passed away at birth who in retrospect we think had hypophosphatasia. But it's, and talking about the importance of advocacy groups, it's this initial family and in this initial family, so this couple really worked with me and spearheaded the work that we did to try to identify why is hypophosphatasia so common in Manitoba and in Canadian Mennonites for that matter. And without this partnerships, and I've always worked with partnerships in the community, we never would have been able to identify the cause. So I'm very grateful and still, of course, keep in touch with our families who are complete partners in the research endeavor and allowed us to determine the cause of HPP in our population. Next slide, please. I think I wanted to just show, Deborah showed a bit of a wheel what the advocacy group does, but as a geneticist, the way that I've always worked is I'm here to help serve families and patients. But it starts with a clinical problem, and throughout my academic career, We've taken a clinical problem, worked in partnership with communities, identified the gene, identified the mutation, try to identify how that mutation causes the disease, and then work on developing treatments or screening programs or ways of going back to the community and complete this whole wheel of knowledge translation. So I've worked very closely between clinicians and basic scientists, always with the individuals and the families in the world, in our communities, helping link us together. Next slide, please. Just a background for those who may not be familiar with what a genetic disease is. It's also a hereditary disease. Inherited disorders are genetic disorders, and we inherit our genes from our parents. And our genes really determine most of our physical characteristics and our health for that matter. When there is a misprint in a gene, which is just a series of nucleotides in the DNA, misprint is also known as a mutation. A misprint or a mutation can be benign. It doesn't have to be disease-causing, but it also can be disease-causing. And we have rules when we identify mutations in genes that help us decide whether a mutation is benign or if it's in fact disease-causing. If you inherit a mutation from both parents, shown on the right here, and the parents are known as carriers, but unaffected with a genetic disease, the individual shown in red here who has a disease has two copies of mutation, one from each parent, and that's known as an autosomal recessive condition. If a parent has a condition and only in one copy of the gene abnormality is needed to cause the disease, so the gene copy is normal from the unaffected parent, this is known as dominant, autosomal dominant inheritance. Next slide, please. Hypophosphatemia is a genetic disorder. There's abnormalities in the sequence of the letters in our DNA. We can have families that have only one affected member, or we can have families that have multiple affected members. Sometimes you find a dominant form of hypophosphatemia family where neither parent is known to have any mutation, and that can occur by what we call a new dominant mutation. Now, what causes a mutation in the DNA to occur in the gene that causes HPP is really not known. We don't know the cause of genetic mutations. I always tell our families when we see a new mutation, I'm certain that it's nothing that you did or didn't do in any way that caused it. You know, we have 3 billion nucleotides or letters of DNA in every cell. It's unusual for one to undergo a mutation. Sometimes we can repair that mutation in the DNA, or sometimes it can lead to the disease. But in hypophosphatemia, in the gene that causes it, there's well over 260 different misprints in the gene that have been linked to HPP. Next slide, please. Who has hypophosphatemia? As I told you, and as Deborah mentioned, it's really on a clinical spectrum. Can be diagnosed before birth, in utero, at birth, what we call around the time of birth, perinatal, in infancy, in childhood or adolescence, and then adults. And the signs and symptoms vary from patient to patient, varies from patient to patient within families and between families. And not everyone with hypophosphatemia has to have every symptom. Next slide, please. I know that HPP, as an inborn error, is an inborn error of mineralization of the skeleton. So calcium is not able to deposit in bones. You either get rickets, if you're a child, or osteomalacia, soft bones, as an adult. That's the hallmark of the disease. Many patients have dental abnormalities, such as loss of baby teeth or adult teeth, earlier than normal. And go through some of the features in future slides. Next slide, please. So showing the clinical spectrum of the 6 main types of hypophosphatemia. We talked about the type that is identified right at birth, being the perinatal, most severe, very often lethal form of hypophosphatasia, to the mildest form, the odontohypophosphatasia, just caused by missing teeth. On the top here, I put the infantile form, and I put benign prenatal here because although it's often diagnosed prenatally, you don't know that it's really going to be benign until you actually follow the child, who then survives and improves and may not be diagnosed until childhood, but it may have had its onset prenatally. So there is a benign prenatal form that's very important to remember, and sometimes difficult to distinguish, knowing what course the baby is going to follow when you diagnose a child antenatally, whether it's going to follow a very severe perinatal course or whether it'll be a benign prenatal form that was diagnosed prenatally. But most of the time we'll see children either around the time of birth, in childhood, or in adulthood. The forms that are the most severe, the infantile or the perinatal, are always autosomal recessive. The other forms, sometimes the milder childhood forms or the milder adult forms, either be recessive or they can be dominant. And this showing various clinical manifestations of baby with severe infantile hypophosphatasia, showing this abnormalities in the ribs, that's called the rachitic rosary, and some of the complications of the disease. This, I said, was the perinatal or very severe prenatal form, and this is siblings with juvenile hypophosphatasia, and you can see the differences in families, even within the same family. Also, with hypophosphatasia, we'll go through their signs and symptoms in the next few slides. Next slide, please. So the infants who are born with HPP generally have short limbs. They'll often have an abnormal narrow chest. They can have bowing of their long bones and very, very soft skull bones. If you don't have the perinatal form, and usually they have some cummed rate at birth, if you have the infantile form, you can present with seizures, breathing difficulty because of the very narrow and soft chest wall. You can have kidney problems because of calcium deposits in the kidney, and high calcium levels that often cause vomiting and feeding difficulties, and they have problems gaining weight. And the younger the child presenting in infancy, they generally have the more severe forms of infantile hypophosphatasia, or the lethal form that it's called the perinatal form. Slide, please. And this is so the x-rays taken from babies I have seen with the perinatal form, born at birth. You can see that almost cannot see the mineralization of the skeleton, just small islands of bone that you can see in 3 different children who have perinatal hypophosphatasia. Next slide, please. Infants with hypophosphatasia in our population would be in the same families as the perinatal lethal form. And infants with hypophosphatasia, these are 3 x-rays of the same child showing progressive worsening of the x-rays in a child with in an infant with HPP. Next slide, please. This is the most extreme case of showing what happens to what is the natural history of severe infantile HPP. It's one of progressive skeletal demineralization. So this is the x-rays of a baby with severe infantile HPP at 4 months of age. She was maintained on a ventilator for her life, and at 36 months of age, she was alive and on a ventilator. But you can see, untreated, there was progressive loss of mineral from her bone, and basically no skeletal mineralization, or very little identified. Next slide, please. In adults, in our population, I should add, when we identified the genetic basis for the perinatal and infantile forms, it was the same 2 mutations. And our children in the Mennonite community and our adults in the Mennonite community also have the same 2 mutations. One of them, the very severe one, as you see in the infantile or perinatal form, but the second one is a milder form. So again, it's a recessive childhood as well as adult hypophosphatasia in our population. And why some present in childhood and some may not come to medical attention until adulthood, it's obviously a moving target, but children may present with short stature, and they may come in with bowed legs, and it may look like vitamin D deficiency rickets. They may have delayed walking or delayed milestones, as Deborah mentioned, very early loss of baby teeth. One of the features that we've seen in children is a kind of a non-progressive myopathy, chronic muscle or bone pain. And pain is a feature of certainly adult hypophosphatasia, but it can also be a feature of childhood HPP. And the children can also present with joint pain or swelling. Next slide, please. Just an example of a typical case history with a child that we saw who presented at 1 year of age with a loss of baby teeth. At 19 months, this child had a craniectomy because of fusion of the skull bones, and it's paradoxical fusion. If you're not putting down mineral, how do the skull bones get fused? It's essentially what's called a functional craniosynostosis. You can see very poor mineralization of the skull, yet the sutures are still fused. And if there is increased intracranial pressure, often the neurosurgeon has to do a craniectomy. And our patient had a craniectomy, and in fact had 2 craniectomies in childhood. And at 3 years of age, he grew fairly well, but he had knock-kneed, or what's known as genu valgum. He had a very abnormal gait. He kind of swung his hips around to run. And there was a non-progressive myopathy with a lot of muscle and bone pain. Next slide, please. And this is just slides of a child with various different children with different forms of juvenile hypophosphatasia, and the skull is showing increased markings, signs of suggesting increased pressure. Next slide, please. Also, the spectrum of radiological findings in children with HPP showing, you see the abnormal skull shape on the left, and often results in a misshapen skull depending on which sutures are fused, and you can see what's called the copper-beaten skull because of increased pressure. And in juvenile childhood hypophosphatasia, these little triangular lucencies at the end of the long bones are very typical of childhood hypophosphatasia, along with the other poor mineralization. And sometimes it's hard to appreciate the findings of HPP and childhood hypophosphatasia in the knees, but if you look carefully, they are there. Slide, please. The teeth manifestations of HPP in childhood is quite dramatic. The widening of the pulp chambers, that's this X-ray, and frequent caries, enamel hypoplasia or poorly developed enamel, and the teeth that really do not stay embedded in their sockets very well. Next slide, please. Adult hypophosphatasia in our population, as well as adults, you may get a history that they lost their teeth early, and with dental findings I described, and may even give a history of having had rickets in childhood, and then they may not come to medical attention until adulthood, where they present with recurrent fractures or fractures due to osteomalacia. Next slide, please. A typical woman that I saw, she was actually being seen in the breast cancer clinic because her mother and her aunt had breast cancer. And interesting, her mother was followed in our osteoporosis clinic. And osteoporosis is somewhat unusual at their age. Our patient, this 27-year-old Mennonite woman who was referred to the metabolic clinic, had a very low alkaline phosphatase. We'll talk about that later because it's different from lab to lab, but that was low. Next, please. In another case of adult hypophosphatasia, we had a woman who had very poor dental hygiene and lost all her teeth at a very young age, and start to have fractures at 62 years of age with very little trauma. Just twisted her foot, fractured her hip, rolled over in bed, and fractured her other hip. Next slide, please. You can see the hardware that goes into the orthopedic management of severe adult hypophosphatasia in trying to stabilize these fractures and to help mobilize the patient again, which can be very, very difficult. And this is just an example. You can get very, very severe fractures in adulthood, or you get very typically adults will present with stress fractures, shown by this arrow. There's other features of adult hypophosphatasia that I find extremely interesting, particularly the some of the arthritis or the calcium deposits that happen around the joints with calcific arthritis. And it's a bit paradoxical. Again, you get all this calcium in soft tissues, but you just don't get it where you need it in the bone. Next slide, please. These we talked as the mildest form of hypophosphatasia, where you really cannot find other features of HPP, just premature loss of teeth and no skeletal manifestations or other systemic signs. Next slide, please. The signs and symptoms of hypophosphatasia, the hallmark, of course, is abnormal skeletal mineralization, but the consequences of that are multisystemic in nature, from causing neurological problems in infancy, for example, with vitamin B6 dependent or responsive seizures, lung hypoplasia and respiratory difficulties in the very severe infantile forms that may not be right at birth but presents as the child gets a little bit older. By 6 months of age, they can deteriorate significantly from a respiratory point of view. The very high calcium that these kids get because they have nowhere the calcium can go except deposit in the kidneys, causes nephrocalcinosis, can cause high blood pressure. Non-progressive myopathy that we see in many of our children. And from a rheumatologic point of view, first of all, the severe pain that many of our patients, children and adults, suffer, as well as the periarthritis that you see along with these calcifications around the joints that can be very, very painful. So the whole spectrum of signs and symptoms in the various clinical forms of HPP. Next slide, please. So how do you make the diagnosis of HPP? I think many of you who are listening know that it's been a diagnostic odyssey, and the group and increasing awareness of hypophosphatasia as an important cause of fractures in osteoporosis clinics, etc., and rheumatology clinics, through your dentists. You know, you've done a fantastic job in increasing awareness of thinking of HPP based on the symptoms and signs that people show. Of course, if you have a family history of confirmed HPP, it makes it a lot easier for your healthcare professional to suspect it. And families with HPP may have family members diagnosed, or in retrospect, you can make that diagnosis. Next slide, please. Into what is causing the abnormal skeletal mineralization. So like this cartoon shows a bone cell. And on the bone cell, on the surface of the bone cell, is the normal protein, alkaline phosphatase. And you also have the normal substrates that alkaline phosphate have to act on, in this case, pyrophosphate. And when you have normal alkaline phosphatase, you can cleave or break this down into two phosphate groups that can then join with calcium as calcium phosphate hydroxyapatite and precipitate as normal bone. In hypophosphatasia, if you're missing the ALP, the alkaline phosphatase, the pyrophosphate accumulates. Pyrophosphate in itself is not good for you. It inhibits bone turnover. It also can deactivate whatever alkaline phosphatase you might have, and it inhibits skeletal mineralization. So you may have a lot of calcium hanging around, but you cannot create the phosphate, lack of alkaline phosphatase, and therefore you don't get the skeletal mineralization. It's absence of skeletal mineralization that is the hallmark of hypophosphatasia. Next slide, please. To confirm the diagnosis, if you suspect it clinically, if you have positive family history, you need one blood test ordered, and there's a blood for alkaline phosphatase. Excuse me. The normal values for alkaline phosphatase vary from lab to lab, but every lab really should have its normal values that are very much age and sex dependent, and yet a low value of alkaline phosphatase, if you're a health professional, we as doctors often, ignore low values because we're always looking for elevated this or elevated that, but have to pay attention to low values of alkaline phosphatase. We've had a variety of meetings recently, and the question always arises, can you have hypophosphatasia with a normal alkaline phosphatase? And, well, I don't think so. But I have to qualify that by saying a normal alkaline phosphatase, you have to know what the lab is measuring. For example, there are different forms of alkaline phosphatase. Placental alkaline phosphatase, the levels in pregnancy would naturally go up, so I don't depend on the level of alkaline phosphatase during pregnancy. Intestinal alkaline phosphatase exists. These are all encoded by different genes than the bony form of alkaline phosphatase. That could also falsely elevate the level of alkaline phosphatase. If you're looking at the alkaline phosphatase during an acute fracture, for example, when the alkaline phosphatase can often go up normally, that's not a good time to screen a patient for HPP. At the same time, you have to remember how the level of alkaline phosphatase changes with time. It's highest in the youngest child, and it gets lower as you get older. It's generally higher in males than females. So you really have to pay attention to the value of alkaline phosphatase, the clinical state of your patient, the gender of the patient, and whether or not it's being taken during pregnancy or not. There have been lots of surveys being done now in reviewing from a clinical chemistry point of view, hundreds of thousands of values of alkaline phosphatase. And we've done that here in Winnipeg ourselves when we've looked at, let's say, 30,000 alkaline phosphatases that were sent to our lab by various doctors, in Manitoba. And knowing we have a high prevalence of hypophosphatasia, it's amazing the numbers that we have that are under 30. Now, that is true other places. Other people have done surveys, and not all low alkaline phosphatases make hypophosphatasia, because there are other things that can cause low alkaline phosphatase. In fact, if you are on steroids, or if you have low thyroid, or if you have deficiencies of certain minerals like zinc, B12 or vitamin C, or if you're in a starvation state, and sometimes patients in ICU in very critical illness can show alkaline phosphatase. So it has to be interpreted in the context of the clinical situation. And again, I would not hesitate, regardless of where you are, and you being the expert in HPP, to talk with a healthcare professional. If you're in Canada, you can pick up the phone and call any metabolic clinic and speak to somebody to help in the interpretation. And I know as advocates that you will continue to follow through and ask to know what an alkaline phosphatase level and get the normal ranges for a lab. Here in Manitoba, knowing we have a high frequency of hypophosphatasia, we actually have a flag alert on every value of alkaline phosphatase that is less than 30. The report goes out to the doctor with an asterisk that says low alkaline phosphatase may be indicative of the metabolic bone disease known as hypophosphatasia that is overrepresented in Manitoba. Please call the metabolic specialist. That's myself or my colleague. So we've had calls for sure, and we have identified rare cases, but I'm sure there are many more patients out there who are not being diagnosed. Next slide, please. emphasize the lack of activity of tissue nonspecific alkaline phosphatase is the hallmark of the disease. You're lacking the liver test ALP. You get elevations of the substrates that the enzyme should normally act on. I talked about elevations in PPI, but you also get elevation in vitamin B6 form known as PLP that can lead to seizures because of your of a deficiency of the active form pyridoxal in the brain, and you can get other substrates that can help you make the diagnosis of hypophosphatasia in context of a low alkaline phosphatase. PLP is not done in most labs. Even in Winnipeg, it's a send-out test, and it takes quite a while to get the results. PPI is also not a readily available test, and it's often done just on a research basis. Phosphoethanolamine is done in most labs that have metabolic labs because it comes out on either a mass spectrometer or on organic acid analysis. I'm not going to talk about the genetics of HPP. I told you there's well over 260 different mutations in the gene encoding the tissue nonspecific form of alkaline phosphatase, and there's certain mutations that are called founder mutations in distinct population. A genetic analysis to me is not essential for the diagnosis. You take a good history, a good physical, other laboratory findings, X-rays, good and consultation, with metabolic specialists, endocrinologists, or people who are experts in the disease. Next slide, please. I think talk a lot about, and I know all of you can speak much better than I can to what it means to have hypophosphatasia. Know that without treatment, HPP is a very debilitating disease, and it's a progressive disease. And without treatment, many patients suffer and could continue to suffer with progressive disease. And in infancy, I said it could be life-threatening, but of course it's very debilitating. It can be in all age groups. Many of you know that walking may be difficult. Assisted devices and home modifications are often necessary. Often patients require an adult to the aids of personal assistance and ongoing physical therapy. And for some, of course, the signs and symptoms may be much less severe. But currently, there is no approved treatment for HPP. The treatment remains supportive. Next slide, please. This is my last two slides, and I think, of course, all this is available on the Softbone website, all the resources that are available for patients with HPP. I can't emphasize enough the importance, I feel, of advocacy groups. And I think many of you who are involved in advocacy groups, a tremendous energy, and I always worry about burnout of being able to sustain the advocacy that organizations such as Softbones have. And that's why it's important to reach out for others to continue to take up the torch and work with families, because as you know, health professionals, good health professionals, always listen to patients, and you know that governments listen to patients, and I do. So I consider you partners in this journey. Next slide, please. So I'm up here. I think we have a few minutes for questions. This is the Research Institute of Manitoba, Children's Hospital Research Institute, where I have my research office. As you know, we've been very much involved in clinical trials. That's all I really can say about it, but the results are encouraging. And I want to thank all the families who come from around the world to Winnipeg, sometimes and most often in the middle of winter, if you can believe it, and stay here. And I want to thank them all for their incredible dedication to their children and to their families, and all the staff in the Research Institute, the hospital. None of this could be possible as we move forward without the support of everyone, from the patient to the institutions where we work, to government, and of course the advocacy groups. So I want to thank you all, and we take questions.
Oh, thank you so much, Dr. Greenberg. That was Awesome. I know I always learn something every time I hear somebody present, but we did get several questions, so I want to jump right in. One of the first questions was, do you recommend that all HPP patients get a full genetic screening? I also would add, and carriers, and if so, what are the benefits and drawbacks, for example, insurance coverage and kind of flagging that you are potentially a carrier of disease?
That's a very good question. As I say, we know there's both recessive and dominant forms. And we know, and I want to make one thing I haven't said, but we have published this, that the form of hypophosphatasia that we see in our Mennonite patients, it's the same form of hypophosphatasia that's seen worldwide. And it's not any different than any patient with hypophosphatasia. And that was important for us to publish, to make sure that we know that our natural history is the same as anybody else. But we published, and people know that carriers also have low alkaline phosphatase. So sometimes genetic analysis is necessary to try to distinguish between an affected person with 2 known mutations in the family or just a carrier of a single mutation. Carriers of a single mutation in the recessive form actually do not have any symptoms. By and large, most of our carriers are fine. We do have a few carriers, as they've gotten older, have come down with some stress fractures. But I think genetic analysis is just another piece of to try to put the puzzle all together to decide if somebody is affected with 2 mutations of a recessive form or just a carrier. But at the end of the day, I mean, not everybody in every center, let's say in the U.S., Canada, or Europe, have ready access to DNA testing and molecular diagnosis. And but I think, used selectively, it can be very helpful to help put the puzzle together. But I don't think for most cases it's absolutely essential. Now, in this molecular era, it's often done. But I think when you're questioning, should people have genetic analysis in terms of, being able to have access for insurance and job security or any discrimination in the workplace. I think personal health information is personal health information, and no health professional should disclose personal health information without the permission of the patient. So, of course, I think it's important to get as much insurance as you can, but if a genetic analysis is necessary, I don't feel, and no health professional should disclose the information without the permission of the client, of the patient.
Okay, thank you very much. Okay, bunch of other questions here coming in. I'm going to jump to a cluster of questions that we got around pain. Some asking if a rheumatologist might be a beneficial partner in dealing with the muscle and joint pain, or if you have any recommendations around treating pain with pseudogout or general muscle joint pain. There's several questions on that, so I wanted to make sure I included that.
Yeah, thank you for that question. And, for those of you out there with HPP who suffer pain, my heart really goes out to you because I know how severe the pain can be. I could feel it, from speaking and seeing so many people. The one thing about pain, and I'm not a pain expert, is to try to involve pain specialists and to use whatever modality you can to help manage pain. Like, this is a long-term chronic problem. And I think medications are very important. But I've seen some of our adults who run into problems because of misuse or overuse of medication. For example, non-steroidal anti-inflammatories. If they're abused, they themselves can cause chronic kidney damage and kidney failure. So pain medication has to be administered, by people who know a lot about pain. And I think the pain clinics and pain specialists, they're very hard to get into in Canada because there's a long waiting list. But I think it's well worth the wait. It's important to keep as mobile as you can to try to minimize, the joint contractures, physiotherapy, passive motion of the joints, and trying to stay as mobile as possible is very important. But I know that pain is a huge problem. Thank you.
Sorry. One more question. How does one tell when HPP patients who have elevated blood pressure, if it could be due to calcification of the kidneys, what would be the appropriate treatment or testing to determine this?
Very good question. A single measurement of a blood pressure is no good. Every time I go to the doctor, my blood pressure is high. Then he makes me lie down and rest for half an hour, and he says, Cheryl, you have a stressful job. That's why your blood pressure is high. You have to rest more, which, of course, I can't do, right? So, you know, you go to the doctor, and you're stressed, you have pain, your blood pressure is going to be high. So I think hypertension in patients with HPP, you have to have multiple measurements. Often 24-hour outpatient blood pressure monitoring, I think, is essential to really get a good feel for what is your blood pressure doing. In general, the calcium deposits in the kidney, the nephrocalcinosis, does not affect renal function. That being said, we certainly see a lot, you know, sometimes of hypertension, and, you know, hypertension is so common in the general population that I would look at for other risk factors and not only blame it on the HPP and the calcium deposits. And a workup in terms of the kidney function and looking for protein excretion in the urine can sometimes definitely help. I think seeing a nephrologist or an internist to help decide if this is true hypertension and its management is very important. Remember, hypertension is a multifactorial condition, and there's often confounding factors besides the HPP.
I'm going to ask another question that we hear, came in from somebody, but we hear a lot on our Facebook pages and other forms of communication, and that's the ALP level is 9, but it's tested lower, sometimes higher. You know, does a change in the level indicate anything?
No, I don't think so. It's very low. Whether it's 9 or 13 or 20 or 15, you know, you get natural variations, you know, from batches of tests in different labs. But, you know, once you've established a low alkaline phosphatase, and based on other signs and symptoms, or maybe some other biochemical testing or genetic analysis, you've made the diagnosis, it isn't really necessary to repeat the alkaline phosphatase. It doesn't really tell you much.
One more question, and then I'm going to try to wrap it up because I know we wanted to try to keep this to an hour. And again, we will answer all of the questions in one form or another, hopefully in a written format. We've collected all of them, and we will answer after the webinar. But this question, I think, applies to a lot of people. That's, you know, where I recommend that adults with hypophosphatasia treat medical assistants. You know, some of them have endocrinologists, but they seem to be focused on bones, but, you know, you have issues of muscles and joints. This person was from Canada, so they were asking particularly in Canada, but I think it's also kind of a good question from a specialist perspective.
Very good question. It's not an easy question to answer. I mean, the key for all these rare disorders that involve so many systems, and that, you know, as I think you've done in some areas, is really a multidisciplinary clinics, and as you have done on your board of soft bones, having all the different specialists in one place and being able to access all the specialists you need with one visit, particularly if you're debilitated or have fractures and have a lot of pain. The innumerable number of appointments, that in itself is a daunting task. So I think it is very hard to say, name one specialist for hypophosphatasia when there's so many systems that can be involved. The answer really is a multidisciplinary clinic. You know, one of the concepts that we talk about in Canada, and I'm sure in the States, is that patients should have a medical home or should have a case manager. I mean, this ideal thing, I mean, you guys are wonderful in being advocates for yourself, but not everybody, has that ability. But if everybody could have a case manager and direct traffic and get that one health professional, to make sure that, all systems are covered, that would help, I know, many, many patients. To pick one healthcare professional who's going to be able to really navigate an adult hypophosphatasia patient with recurrent fractures and severe pain through the system, who may or may not have a high calcium, who may have high blood pressure. It's very hard to put that on a family doctor. I think, and of course many family doctors find that, very daunting. There isn't an easy answer to that, and depends. It's very dependent on every different case. I dream one day where you'll have nurse practitioners or other healthcare professionals that could work with family doctors for very specialized cases and be case managers and help patients navigate through the system. That's what we need, even for rare disorders.
Well, it's 5 Eastern time, and I know that again we have collected all these questions, and we're going to follow up with Dr. Greenberg to make sure that we get you answers. And first, Dr. Greenberg, I can't thank you enough for your time and for hearing your expertise and your just knowledge to spend the whole hour with us tonight. I know that I speak for everybody on the line when I say thank you. And we appreciate you and your dedication to studying hypophosphatasia so much, and words just really can't express our collective gratitude.
Well, nothing but admiration for all of you, and nobody give up, right? You just keep that fight going, and I'm happy to help in any way I can, and anyone can call me at any time or email me. Help in any way I can.
Thank you. In conclusion, I just want to thank everybody on the line so much for your time and engagement tonight, and I hope that you found this webinar valuable, and we look forward to your feedback and bringing you more opportunities like this in the future. And again, a thank you for the collaboration with Global Genes. So thank you everybody for attending, and have a wonderful evening.